Thank you for the kind invitation, ladies and gentlemen. And so thanks for the kind invitation. It's a great environment, and I'm not sure that I ever gave a lecture in such an environment. So thanks for having me here. This is my conflict of interest slide. I'm having interaction with various companies in the field, but don't take any personal honoraria. What I'm going to do over the next 30 minutes or so is to discuss the pathophysiology of heart failure in diabetes, look at epidemiology and prognosis, and then on the effect of glucose lowering itself and certain glucose lowering drugs, and finally end with the most recent data that were raised on SGLT2 inhibitors in heart failure. Just to bring everybody on the same page, in heart failure, we can distinguish heart failure with reduced ejection fraction where the contractile function is impaired, and unfortunately the MRIs are not running, but this is what we call now HFrEF. The second form of heart failure, which used to be diastolic heart failure, is HFpEF, heart failure with preserved ejection fraction, which has a preserved contractility but an impaired relaxation leading to impaired ventricular filling and an increase in filling pressure, which, for example, when the blood pressure goes up, may lead to pulmonary edema here. And then the European Society of Cardiology 3 years ago introduced a new third entity you may have heard of, which is called HFmREF, heart failure with mild mid-range ejection fraction. And here the ejection fraction for reduced is below 40, for mid-range is 40 to 59, and then 50 and above is preserved ejection fraction. Don't ask me why we introduced that, because there are so far no data suggesting that this is exactly the ejection fraction where we should separate one from the other. But we learned that preserved and reduced, there's something in between, and it's kind of arbitrary to define that, but it's important to keep that in mind when you look at clinical trials that were published now. It's important in diabetes that 50% of all patients hospitalized in the emergency rooms for decompensation have HFrEF and 50% have HFpEF. So if someone undergoes echo, it's important to not only look at systolic function but also at diastolic function. So let's look at the pathophysiology, and I show you a nice slide published 5 years ago suggesting that many of these factors contribute to what has been called diabetic cardiomyopathy. And if you see one of these slides, I think everybody knows that it just tells you that no one has an idea what is really going on. And the term diabetic cardiomyopathy is, I don't like that term very much because it suggests that this is a special entity, but probably it's an accumulation of certain factors that contribute. With respect to the metabolic changes, we published a couple of years ago a summary here putting together the metabolic changes in diabetes and its consequences in the heart. And you have increased free fatty acids in diabetes, you have insulin resistance with hyperglycemia and hyperinsulinemia. And these components contribute to changes in the myocardium here because free fatty acids lead to an altered myocardial metabolism, an increase in fatty acid oxidation, which leads to a decrease in myocardial energy production and also affects calcium handling, which is important for contractility and relaxation. And this contributes, among many other factors, to systolic dysfunction. Then hyperglycemia leads to oxidative stress, which contributes to myocardial apoptosis and fibrosis. In addition to that, drives the deposition of advanced glycation end products, leading to not only myocardial stiffness, but also to microangiopathy, and also drives inflammation, which again contributes mainly to apoptosis. And of course, hyperglycemia activates the hexosamine pathway, also changing calcium handling here, contributing to impaired diastolic function. And insulinemia, hyperinsulinemia itself, at least in experimental models, contributes to myocardial hypertrophy, which also leads to diastolic function. All these components have various interactions and contribute to what has been named diabetic cardiomyopathy. And in addition to that, you have risk factors like hypertension, you have coronary artery disease and arterial stiffness that also alter the myocardium. Let's look at the incidence and the prognosis here. And this is very old data, published 15 years ago. And I think we have to admit that both diabetologists and cardiologists did not really pay attention on the fact that heart failure is important in diabetes. And this is data published 15 years ago, looking at the incidence of heart failure in diabetic and non-diabetic subjects by age. And you can see, no matter how old someone is, if he has diabetes, his risk to develop heart failure is tremendously increased, about 2 to 2.5-fold. And it has an impact on the prognosis here. And this is also data published from the same year, looking at subjects without diabetes and heart failure mortality. And I made that line here, 3-year mortality. After 3 years at that time, 55% of all subjects with diabetes died. This is 15 years ago. Let's look at more recent data. This is 2008, also 10 years ago. This is data from the CHARM program. There was a study looking at the effect of an AT1 receptor blocker on heart failure. In blue is diabetes, in red no diabetes. Heart failure with reduced and preserved ejection fraction, and again in non-diabetic subjects. And as you can estimate here, if someone has diabetes compared to his non-diabetic counterpart, the risk of CV death or heart failure hospitalization is tremendously increased, in particular if patients with diabetes suffer from HFrEF, suggesting that patients with diabetes exhibit an increased risk for mortality and heart failure hospitalization, and the prognosis in HFpEF is still better than in HFrEF. Again, data published 10 years ago. Data published a few years ago come from the Paradigm study. There was the study that examined the new component, the Entresto, in patients with heart failure and reduced ejection fraction. And if you only look at cardiovascular death here, comparing subjects with diabetes here in the upper part and then normal HbA1c here, you can see an increased mortality of cardiovascular death. And after this follow-up of a little bit more than 2 years, 1 in 5 patients with diabetes has died at this point in time, and mostly driven by cardiovascular mortality. And I think that it's fair to conclude that heart failure with recurrent hospitalization and a high risk for CV death and total mortality is one of the leading problems in type 2 diabetes in 2019. And as said before, I think this has been largely under-recognized by many of us. Let's look at the effect of glucose lowering itself on heart failure. You know the UK-PDS data suggesting that an increase in HbA1c is a risk factor to develop heart failure. And the question is, does an intensive glucose-lowering strategy compared to a more conventional strategy reduce the incidence of heart failure here? And this slide nicely summarizes this. This is a meta-analysis of the 4 big studies, ACCORD, ADVANCed, UK-PDS, and VADT here, looking at intensive control versus less intensive control. And you can see here the line of unity. Intensive glucose lowering itself, at least in these studies, and this is early diabetes and this is advanced diabetes here, does not have any effect on the incidence of development of heart failure here. The question is, are there certain differences with respect to drugs here? And the last part will focus on SGLT2 inhibition, but let's look at the other drugs first. So insulin data from the ORIGIN trial here, not suggesting a harmful effect. DPP-4 inhibitors, you remember the SAVOR-TIMI trial where saxagliptin was associated with a 1.27-fold increase for heart failure hospitalization. And we were all anxious to see the data from the other trials, and the latest that we published here was Carmelina, and none of the other trials had a similar signal here. So it seems that this is not a class effect, but that saxagliptin, and recent data suggests that it is one of his metabolites, has a problem here leading to an increase in heart failure hospitalization. Most important, it's not a class effect. What about GLP-1 receptor agonists? Some small studies suggested that there's an impairment in left ventricular function here in a study called FIGHT. But if you look at the large cardiovascular outcome trials, there's no signal suggesting that the use of a GLP-1 receptor agonist has negative effects on heart failure endpoints here. And of course, the old data with the glitazones here, proactive with pioglitazone or record, we know that patients with pre-existing heart failure in these trials had an increased risk for heart failure hospitalization with TZDs, and so these drugs should certainly be avoided. I don't know about Italy, but in Germany they don't really play a role. But we've seen the SGLT2 inhibitor trials, and I'd like to focus on that and also share with you some of the more recent data that we generated on mechanisms. So let's look at SGLT2 inhibition in heart failure in patients with diabetes first. The mechanisms, I think everybody's aware of that SGLT2 inhibitors block the receptor in the proximal tubule here, leading to an increased urinary excretion. And this goes along, since this is a sodium co-receptor, this goes along with an increased sodium excretion. And this may be of particular importance when we're talking about heart failure here. I'm sure you're aware of the data. I just put together the large cardiovascular outcome trials and the endpoint of heart failure hospitalization or CV death, highly significant reduction by empagliflozin, canagliflozin, or dapagliflozin. And the data suggested that these drugs reduce the combined endpoint of heart failure hospitalization or CV death. Now it's important to see to what extent is this driven by the weaker endpoint of heart failure hospitalization or CV death here. And if you look at heart failure hospitalization here in EMPA-REG outcome, very robust, very early effect here, early separation of the curves here. And this was also seen in the CANVAS program comparing canagliflozin versus placebo, highly significant effect. And if you look at DECLARE here, this is a different way to show it. Again, the same reduction in heart failure hospitalization in this very different population. Remember, DECLARE had a population 40% CVD, 60% no CVD, but also in this population, significant reduction of heart failure hospitalization. This was a little different when you look at CV death here. EMPA-REG outcome had the high-risk population, enrolling patients with cardiovascular disease at baseline here, and as you may remember, a highly significant reduction of this endpoint, CV death, in this trial. In the two other trials, in the CANVAS program and in the DECLARE trial, there was no significant reduction in CV death, in my view, most likely due to the fact that the population wasn't as sick as the population in EMPA-REG outcome, and with respect to the duration of the trial, this didn't reach significance here. The next question is, does this reduction in heart failure related endpoint, is this true in patients with or without heart failure at baseline? And there's a very nice paper published in the Lancet beginning of this year looking at these three trials, looking at patients with history of heart failure and patients without history of heart failure. And as you can see here, the point estimate favors the treatment with an SGLT2 inhibitor, irrespective of the presence of heart failure or not. And remember, in these trials, it was only a tick box diagnosis whether someone had a history of that. But these data suggest that EMPA, CANA, and dapagliflozin reduce heart failure hospitalization or CV death in patients with or without heart failure at baseline. The next question is this effect true only in patients with cardiovascular disease or also true in those with multiple risk factors? And here, if you look at the data, as said, EMPA-REG outcome all had vascular disease, and the two others had the group with multiple risk factors, in CANVAS 40% and DECLARE 60%. And as you can see here, the point estimate reaches significance here for the endpoint CV death or heart failure hospitalization in the group of patients with ASCVD, while there's a trend towards a reduction in this endpoint in those with multiple risk factors but did not reach significance. You know, it's a subgroup analysis of a meta-analysis of subgroup of studies. It's at best hypothesis generating, but I think it's fair to state that the effect of these drugs on heart failure hospitalization or CV death is more pronounced in patients with ASCVD compared to those without ASCVD. The next question is this effect also true in subjects without diabetes? And you mentioned the trial that has been released at the European Heart Meeting, which is the DAPA-HF trial, and I'd like to share these data with you because I think from a mechanistic point of view there are a lot of important points that we can learn here. DAPA-HF randomized 4,700 patients to dapagliflozin 10 milligram or placebo. Inclusion criteria was an ejection fraction 40 or lower and symptomatic. So there was a pure HFrEF population here. They had to have a certain NT-proBNP level here or hospitalization, or higher if they had AFib. Exclusion criteria was a low eGFR here and symptomatic hypertension or type 1 diabetes. And the primary endpoint was a combined endpoint of worsening heart failure or CV death. And this is one of the first trials that used a little different endpoint here, because worsening heart failure had two components. The first one was unplanned heart failure hospitalization, and the second was urgent heart failure visit requiring intravenous diuretic therapy. At this point, the investigators wanted to include patients in this endpoint that were hospitalized in the emergency room for maximum 24 hours, receiving IV loop diuretics, furosemide, for example, and then they ticked the box for this endpoint here. If you look at the baseline characteristics here, typical population mean age 66, ejection fraction 31. This is pretty low already. So these are at usually if you follow the guidelines, this is a population that should have an ICD, for example, which 26% of the patients had. But for the lecture here, prior diagnosis of diabetes, 42%. So 60% had at least undiagnosed diabetes or no diabetes here. And if you look at the data, and I'm sure you saw the data here, dapagliflozin compared to placebo significantly reduced this combined endpoint of CV death or worsening heart failure with a relative risk reduction of 26%, and the number needed to treat over this follow-up of less than 2 years of 21, which is a pretty low number. And being a cardiologist myself, in the field, this has really raised a lot of attention, and this will be a game changer, because for years this has been the latest or the most important drugs that really reduce this effect in such a short time course. And again, you see this very early separation of the curve. If you dissect the endpoints here, looking at worsening of heart failure and CV death, both have become significant here, highly significant, not only worsening of heart failure, but also CV death. And so the next most important question is, what about non-diabetic subjects in this population here? And if you look at all patients here, this combined endpoint, and then dichotomize in those with diabetes and without diabetes here, diabetes yes, diabetes no, you can see there's no difference. So the benefit is present irrespective of the presence of diabetes. And I think this is important to understand when we think about the mechanisms here. And finally, if you see a reduction in CV death, you're always interested to see whether you see a decrease in all-cause mortality, but this has also been shown here for dapagliflozin in the whole population. So to summarize this study, dapagliflozin significantly reduces heart failure hospitalization, CV death, or all-cause mortality in patients with heart failure with or without diabetes. So the next point I'd like to address is the mechanisms of action in this context here. And if you go back to 2016, every big journal, Diabetology, European Heart Rate and Circulation, every big journal published an article, and I can say we contributed to that, because if no one knows about the cause and the mechanism, everybody's free to speculate and publish data here. And so please remember, in 2016, we all used squares to draw our pictures. We kept publishing in 2018 and all independently used circles now, whatever this means. But I think the summary here is still many hypotheses but little data. So let's look at the data. What do we have here? Let's look at classical risk factors. Glucose lowering is very unlikely to contribute, in particular given the DAPA-HF data now that has no that non-diabetic subjects have an effect. Blood pressure lowering may contribute to a certain extent, but the blood pressure lowering does usually in heart failure patients not reduce mortality. Weight loss may contribute to a certain extent. Reduced arterial stiffness has been a hypothesis, but I think it's fair to summarize that even the combination of these effects is unlikely to solely explain the results seen in empiric outcome, the CANVAS program, and DECLARE. And so let's look in more detail at more recent data. And there's some data suggesting hemodynamic effect and others suggesting metabolic effects. And let's start with a look at the hemodynamic effects. There's a very nice paper published 2 years ago by a German group in Erlangen, Roland Schmiede's group, and they looked at the effect of empagliflozin on hemodynamic parameters. and they used as a readout central systolic blood pressure. Central systolic blood pressure is a surrogate for afterload. It's determined mainly by the arterial stiffness and has been linked to future cardiovascular events here. And they did a crossover randomized trial in a little bit more than 70 subjects for 6 weeks. And to make a long story short here, this is the net effect comparing placebo in red versus empagliflozin in blue. They found a significant reduction in central arterial blood pressure and a significant reduction in central blood pressure and some other markers, suggesting that empagliflozin exerts beneficial effects on vascular function and central hemodynamics. We took a different approach. If you look at the endpoints here, heart failure, hospitalization, you see in EMPA-REG outcome this very early separation of the curves. And my group was interested to see whether treatment with an SGLT2 inhibitor has very early and acute hemodynamic effects. And this is unpublished data I'm sharing now with you, and happy to discuss that at the end. What did we do? We randomized 44 patients with type 2 diabetes and cardiovascular disease or multiple risk factors, placebo-controlled double-blind to either empagliflozin 10 milligram or placebo. And at baseline, after day 1, day 3, and 12 weeks, we performed non-invasive hemodynamic measurement with a system called ClearSight system. This is a system that allows you to assess cardiac output and systemic vascular resistance here in a non-invasive way. The primary endpoint that we picked was cardiac index, systemic vascular resistance at these different endpoints, and secondary endpoints were echocardiographic parameters here. So let's look at metabolic parameters. First, urinary glucose excretion. As you can see here already after 1 day, there's a huge increase in urinary glucose excretion, telling us that the drug is really doing what we expect here. And we look at the urine volume here, and empagliflozin in black, you can see there's a continuous increase in urine excretion here. And this is a somehow novel finding, because this drug is acting as an osmotic diuretic continuously. Initially, we were proposing that this is a very early effect, but if you compare baseline versus 3 months, this is about 700 ml, 600 ml more than before. So there's a continuous excretion, and this goes along, and this is very interesting, with a continuous excretion of sodium, which in previous studies, it has been shown in phase 2 studies that if you give an SGLT2 inhibitors, you get an increase in sodium excretion for 1 day, and then it comes back to normal. But if you look at the protocol of these studies, all of these studies have been conducted with dietary and fluid restrictions. And of course, then you see differences. Here, there's a continuous increase in urine volume, and there's a continuous increase in sodium excretion. Let's look at the primary endpoint here, and to our surprise, we did not see any effect, neither on cardiac index nor on systemic vascular resistance. We did not see an effect on the heart rate. We saw a little bit of an effect on blood pressure, but overall, no hemodynamic effects. We were kind of disappointed because seeing these curves, we were expecting that we would see changes here. Secondary endpoint was echo parameters, and I just show you one parameter, which is E to E prime. This is a parameter in the echo that tells us about diastolic function. And already after 1 day, we saw a significant decrease in E to E prime, suggesting that there's an improvement in diastolic function in left ventricular filling here. And this is another way to compare it versus baseline here, suggesting from our study that empagliflozin leads to an acute improvement in parameters of diastolic function here, already present after 1 day. So do we have data supporting this idea that we have a diuretic effect that contributes to unloading of the ventricle and to improvement in diastolic function? There's a very nice study published about a year ago comparing the diuretic effect of an SGLT2 inhibitor versus a loop diuretic here, comparing dapagliflozin versus bumetanide. Bumetanide is not used in my country. It's something like furosemide. And it's a pretty complicated paper, but done by nephrologists, and as a narrow-minded cardiologist, I had a hard time to understand it. But what they did, they looked at the relative reduction of blood volume with the loop diuretic and the SGLT2 inhibitor, the relative reduction of interstitial fluid here, and then they made the ratio, and they could show that SGLT2 inhibitors lead to a relative reduction of interstitial fluid, but to a lower extent to a reduction of blood volume, suggesting that it takes volume from the interstitial space here. And Subodh Verma and John McMurray put that in a very nice cartoon here, suggesting that an SGLT2, that a loop diuretic leads to a reduction in intravasal volume. And this is something you may know from the intensive care unit. You give an IV diuretic, the patients have urine production 2-3 liters and still have these edema and the blood pressure is going down, the heart rate's going up. And this is different if you give an SGLT2 inhibitor, because here you get a reduction in the interstitial fluid, but to a lower extent to the intravascular volume, and that may explain why these drugs do not lead to a reflectory activation of the sympathetic nerve system, for example. So it's a hypothesis, but very interesting, suggesting that SGLT2 inhibitors may selectively reduce interstitial fluid, and this may limit the reflex neurohumoral stimulation that occurs usually in response to intravascular volume contraction with traditional diuretics. I think an interesting hypothesis that kind of fits to our hemodynamic and echo data. So let's shift gears and look at metabolic parameters here. And one hypothesis that was brought up by Ella Ferranini, and we just talked about that a little bit, the ketone hypothesis, suggesting that this mild increase in ketone bodies that you see in patients treated with SGLT2 inhibitors may provide a kind of super fuel to the heart that may improve contractility and have beneficial effects. When Ella brought that up, immediately other papers were published, as we expect in the scientific community, suggesting that ketones may have potential harmful effects, for example, by inhibiting HDAX here or having negative effects on the electron transport chain. The question is, why may ketone utilization play a role in heart failure? And there's a very nice experimental study published a couple of years ago suggesting that in heart failure there's an increase in ketone utilization, and key enzymes in ketone metabolism here in the heart, BDH1 and SCOT, are increased in heart failure. So this could indeed be a mechanism. We performed an experimental study, and this is again unpublished data I'm sharing with you. We took DB mice on a high-fat diet with or without empagliflozin for 5 weeks and looked at these key enzymes involved in ketone metabolism, and we found that diastolic function improved in these mice treated with empagliflozin compared to controls, but this did not have an effect on these key enzymes, kind of at least questioning in our model to what extent this may play a role. Subodh Verma's group published a paper last year treating DB mice with or without empagliflozin here, and they looked for energy production, also a very complicated paper, and they found that SGLT2 inhibition enhances the energy pool by increasing cardiac energy production here from glucose and fatty acids, but not from ketone bodies here. So again, the field is open for discussion. We took a very different approach. We treated patients with cardiovascular disease and type 2 diabetes, 25 patients, on standard antidiabetic therapy, basically matching the EMPA-REG outcome inclusion criteria. And we took blood at baseline and after 4 weeks. And then we performed an untargeted serometabolomic approach. So we basically gave blood away to the lab, asked them to do a metabolite analysis here, and about 1,300 metabolites were found, 1/3 unknown here, and then we gave this list to a statistician, not knowing anything about metabolites and the metabolism, and asked him to do a statistical analysis, and he found out, and the data showed that 162 metabolites were changed by empagliflozin. Next, we took this 162 metabolites and went back to at medical school. We had these huge charts of the different pathways, and we basically flagged every metabolite. We did that on a computer, not with needles. But we took that to see whether we see a certain pattern or a certain pathway here. And to make a long story short, we found that the SGLT2 inhibitor empagliflozin in this patient population increases the catabolism of branched-chain amino acids. Branched-chain amino acids, you may remember that, is valine, isoleucine, and leucine here, and also increases the catabolism of the third ketogenic amino acid, lysine, and that fuels here the TCA cycle, thus leading to an improvement in energy production. So our data suggested that empagliflozin treatment leads to an expanded ketone body utilization, as proposed before, and an increased catabolism of branched-chain amino acids in treated patients. I have to be honest, I didn't know much about branched-chain amino acids in the heart, but this may be important in the context of heart failure here, because there's very nice data suggesting that exactly the catabolism of branched-chain amino acids is impaired in heart failure. So the breakdown of them is impaired. And so they accumulate here in the heart, and this is the mitochondria here, and the accumulation of branched-chain keto acids and amino acids impairs the electron transfer chain, leads to oxidative stress, and activates certain signaling pathways in the heart, altogether contributing to cardiac hypertrophy and dysfunction. Now, having our data suggesting that empagliflozin treatment may increase the catabolism, so kind of overcome and rescue this defect here, the accumulation may decrease, and this may have beneficial effects here, thus counterbalancing the bad effects that have been seen in heart failure. So in summary, I think our data suggests that since branched-chain amino acid catabolism is diminished in heart failure, empagliflozin or probably also other SGLT2 inhibitors could potentially restore these defects, and on the one hand provide an optimal energy source for the heart, and in addition exhibit direct effects on cardiac function by influencing various signaling pathways. So to summarize our current understanding of the beneficial effects of SGLT2 inhibitors, I think one hypothesis is that there's a very early effect due to increased sodium excretion, a decrease in sodium body load, reduction of interstitial volume, improvement of diastolic function very early, while midterm and long-term effects may involve cardiac remodeling, may involve cardiac metabolism and cardiac function. So to summarize my talk, the failing heart and diabetes patients with diabetes exhibit a high risk to develop heart failure. SGLT2 inhibitors reduce heart failure hospitalization in patients with or without heart failure and with or without ASCVD. Some of the effects are independent of the presence of diabetes, most intriguingly shown by the DAPA-HF trial, and several mechanisms seem to contribute to the beneficial effects seen by these drugs. And last but not least, I'd like to thank and acknowledge everybody who did the work. Michael, Matthias, and Kirsten were doing the clinical trial, and Ben, who actually trained with Massimo Federici in Rome, he did the metabolite study. And I thank you for your attention.
Nicolas, great. Thank you very much. Great presentation. And the presentation is now open for discussion. So if you have a question, Stefano, please.
Nico, very nice. Thank you very much. Just one question. From the clinical point of view, the data in terms of heart failure protection from the SGLT2 seems to be mainly expressing people with FREF. This is in the post-hoc analysis in the CLARE from Cato, and this is also in the DAPA-HF that actually selected those individuals.
Yeah.
However, from the mechanistic point of view, you pointed out that the main effect is on diastolic function. How do you reconcile the two things?
Yeah, I think, the data we are having now is the DECLARE study was on the echo with the dichotomizing below 45, I think they did, and the DAPA-HF only shows about HFrEF here. I think we have to await the EMPEROR preserved data, for example, here. My personal view is that there's still some hope for HFpEF with these drugs here, because to be honest, we were disappointed when we didn't see the hemodynamic effects. But when we looked at the echo data, you see a very robust and very rapid effect on diastolic dysfunction. And so I could imagine that in the HFpEF population, you could also have a benefit here, but this is still a hypothesis. I think we have to wait for the clinical trials. And in this context here, the Paragon trial with the Entresto was published at ESC, and we had a lot of hope for this one here. That's the neprilysin inhibitor data here. That was negative. So I think, as a cardiologist, our hope is on the SGLT2s now, but I think it's too early to see it, to conclude on that. Yeah.
Okay. Nicolas, going on with the question from Stefano, I was wondering, you showed us that indeed the major benefit using SGLT2 inhibitors was found in those in secondary cardiovascular prevention rather than those in primary cardiovascular prevention related to an atherosclerotic related event. Mm-hmm. But I have also the feeling that it's very much similar also related to the baseline ejection fraction. If the ejection fraction is worse, the benefit is higher, and something different than what we see related to renal protection. Okay, so the other way around. So it might be expected if you have a worse function, you are going to get a better benefit. On the other hand, it does not go against the hypothesis with those with preserved ejection fraction, we are going to finally see the benefit.
Yeah, I think there are 2 points to it. The first point is the absolute risk. So the HFrEF population, as I showed you from the CHARM data, they have an increased risk. So within that time frame of 2 or 2.5 years, the question is whether you accumulate enough events to see a reduction. This is one point, I think. And the Salnica meta-analysis is from these trials that were not designed for that. I think the only way to answer that is the dedicated trial that looks at patients with preserved ejection fraction here. The problem with HFpEF is that this is a mixed bag of entities here. There's hypertension, there's obesity, there is arterial stiffness, many components contributing to it. COPD, for example, that was neglected. CKD, chronic kidney disease, leads to hypertrophy, and fibrosis leads to HFpEF. And my view, or our view in my department on that is that we need to get a better taxonomy, better characterize the patients and then go from there. And we are setting up a huge heart failure population prospective study, 3,000 patients, where we do deep phenotyping to dissect them better. And I think we need to wait for the PRESERVE trial, and then even if this turns out to be negative, we need to take subgroups and then look at the potential effects.
Giaccari, Andrea?
Thank you. Very inspiring talk, really, really interesting. Trying to compare the 3 different major trials in type 2 diabetes, we have observed the striking results in the reduction of cardiovascular death only in the EMPEREC. And the other 2 trials were different, mostly in terms of population which was enrolled. With less striking results or even nothing in terms of cardiovascular death. And then also the MACE reduction was significant, at least in the first 2, but the numbers were not that striking as was the cardiovascular death. So that the MACE reduction is there, is the primary endpoint, allows us to go further, but that is not the major results of these trials. And then we have the DAPA-HF, where the reduction in cardiovascular death is back and is significant, as you showed us. So my idea, I don't know what's your point, your opinion on this, is that maybe rather than going to atherosclerotic cardiovascular death, maybe all these trials might suggest us that the major reduction in cardiovascular death is due to reduction in people with the reduction in heart failure, hospitalization, or whatever, and it depends on what's the proportion of the population with this risk in the different trials give us the different results. So rather than reducing atherosclerosis, it just reduces, which is important, obviously, heart failure, and this might explain, let's say, altogether. But that's my opinion. I'm not a cardiologist.
No, very, very good point. I couldn't agree more. If you look at the single endpoints in EMPEREC, and I showed you a slide, there's no effect on myocardial infarction, there's no effect on stroke, and this is true for the others. It's only driven by CV death at the end. And it raises the question whether 3-point MACE is the right endpoint here. On the other hand, if you look at the GLP-1 receptor agonists, which lead to reduction in 3-point MACE in LEADER, in REWIND, in SUSTAIN 6, for example, there you see a reduction in stroke and see a reduction in myocardial infarction. So in my view, SGLT2 inhibitors act through a reduction in heart failure-related endpoints, and CV death is one of them, while GLP-1 receptor agonists lead to a reduction in arteriosclerosis-related endpoints, myocardial infarction and stroke. CV death is also one of them, at least in LEADER here. And I think we for all of these outcome trials, we used to say, okay, 3-point MACE or 4-point MACE enrolling and including unstable angina should be the primary endpoint. And I think we can learn from that we have to look at the mechanism, have you look at the data, and then define the primary endpoint, which is also important and beneficial. On purpose, I showed that slide that in 2019, I think heart failure is one of the major problems in diabetes. Yeah. I couldn't agree more.
Console, Agostino?
Thank you. Perfectly delivered speech. I enjoyed it very much. I totally agree with what Andrea and you had said right now, which may be like a call to use them together, right? My question was, on the DAPA-HF trial, I don't remember whether you have seen it or not, was there a subgroup analysis looking at people with ACVD versus people without ACVD, which I guess are very poor, very few given the population?
Yeah, I think they didn't look at ASCVD, but they looked at origin or cause for heart failure, and the major cause was ischemic cardiomyopathy, so driven by coronary artery disease, and there was no significant P for interaction. So irrespective of whether you have dilated cardiomyopathy or whether you have ischemic, you had a benefit here.
Yeah. Ele Ferranini.
Very nice, Nico. One comment and one question. The comment is that the problem with the breakdown of branched-chain amino acids finds some support in some other studies that we published a few years ago, looking precisely at that, because branched-chain amino acids are known to be increased in states of insulin resistance. So we looked at people with prediabetes, and we found exactly what you hypothesized, that there was a decreased breakdown of branched-chain amino acids with accumulation of intermediate metabolites in the middle due to a blockade or some blockade of the branched-chain dehydrogenase, which is the rate-limiting step in branched-chain utilization. So that fits with your metabolic picture. The question I have relates to the use of NT-proBNP as an inclusion criteria, with the expectation that that would be a marker that changes with treatment and tells you the extent of benefit. But there you have the trial that was recently published by Michael Kosigorat, where the primary endpoint was a change in the NT-proBNP, and on average, there was no change whatsoever.
Yeah.
So the question for you as a cardiologist, should we stick to this paradigm, which has been adopted for many years, or should we rethink it?
I think based on Michael's study, I wouldn't take away that paradigm. There's a very nice study looking at subjects with type 2 diabetes, randomizing them to measurement of NT-proBNP. If this is elevated, send them to cardiologists and have them take care of it, versus doing standard care, looking at edema and all that. And in this group, those that had elevated NT-proBNP and were treated by specialists, they had a clear benefit. I don't remember the exact endpoint. It wasn't a hard endpoint, but it's suggestive. I think for the diagnosis of heart failure, it's of crucial importance to measure NT-proBNP. There are certain patients that have elevated NT-proBNP. For example, if you have atrial fibrillation, atrial flutter, this is elevated. Then the threshold is different. Here was 900, and the same we picked for the Emperor trials. But for this screening, it's a very good marker, and I think for your clinical work, of our clinical work, I think it could help to identify patients with diabetes at risk for heart failure here, irrespective of the fact that in Michael's study there was no really a robust effect. Yeah. So don't abolish using it.
Okay. With this regard, Nicholas, you showed us the data related to the DAPA-HF with a very nice, impressive NNT 21, 24. Now I don't remember. But if we take into account, for example, the cardiovascular trials, okay, the NNT is much higher, is 200, is 300. And you are perfectly right. Try to put yourself in the diabetologist's pants and to see in your patient in front of, in the outpatient service every day, in primary prevention, with the possibility to prevent one event of hospitalization for heart failure. How do you try to bet and understand what is the patient in which I would bet in the use of the SGLT2 inhibitors?
Yeah, so I think based on these data, if you have a patient with diabetes and reduced ejection fraction, this patient should, in my mind, receive an SGLT2 inhibitor. On the same token, in our department, and I know I'm more metabolic, I'm none of these hardcore cardiologists. In our department, if we see a patient with cardiovascular disease and diabetes, we give him 10 milligram empagliflozin or dapagliflozin here. We start that immediately because the benefit is so prominent. For the multiple risk factor population, the data suggests that there is a benefit, but with respect to heart failure endpoints, I think for the preserved ejection, we need to wait the trials. But I think, and this is not to take it away from the diabetologists. I want to stay friends with all of you. But in our department, we implemented that. We trained the fellows. We have sick day cards, and we really explain them the important part for the patients here. But these patients should receive the drug because it saves lives.
Enzo?
Thanks a lot. Very, very nice presentation. Two questions. First one, I was impressed by the idea that there is an increase, a decrease in the interstitial volume, or rather than in blood volume. And I'm wondering if there is any other model in which that was demonstrated to be a major factor determining a better outcome. I mean, with a drug or with other kind of procedure. Number one. Number two, going back to the idea that ketone bodies may explain, at least in part, the result. Is there any suggestion written somewhere that people with heart failure should follow a ketogenic diet?
Good question, yeah. We just got Alice laughing. Yeah, there's some experimental or some studies going on. So far, there's no data on that. And it's probably the extent of increase in ketones that may play a role here. Concerning your first question, oh yeah, the reduction of interstitial volume. This is very interesting. Some cardiologists now are saying that this is just another diuretic, but it's not another diuretic, because if you give a diuretic, you get an increase in heart rate, for example. You get an increase in aldosterone. In our study, for the sake of time, I didn't show you, there's no increase in heart rate, there's no increase in aldosterone as a marker of activation of the RAS system here. So this unique effect seems to be a reduction in interstitial volume, but not affecting the intravasal volume. This is probably due to this osmotic effect, but we don't know that exactly. No, there's no other drug. Even we of course, seeing our data, we looked that up. We looked for mannitol, for example, one of these classic osmotic diuretics, but there's no such effect. You always get this activation of the neurohumoral system.